Bismillah Rahman Rahim. Quote of the day is Patience is a pillar of faith. This is the quote by Hazrat Umar ibn Khattab. My name is Dr. Aamna Khalid, and I will be presenting the topic of surveillance under the kind supervision of Professor Dr. Saira Afzal, who is Dean Institute of Public Health. First of all, we will define what is surveillance, which is the systematic continuous collection, then analysis and interpretation of health data, which is followed by dissemination to those who need it for public health action. So the first step is collection, then the analysis, interpretation, and then we do the dissemination of that data. So this is a continuous feedback loop for public health action. And this is the historical background of surveillance that how in 1854 John Snow mapped the cholera cases to identify contaminated Broad Street pump, which was the time of birth of epidemiological surveillance. Then we saw the era of vital statistics systems, where birth and death registration improved the capacity to track disease burden across populations. Then the national surveillance programs in the 20th century, where we saw the emergence of formal disease reporting systems in industrialized nations. And now we see the modern digital era, where real-time global digital monitoring is there, including the AI-driven predictive tools and international frameworks. So these are the objectives of surveillance, including early outbreak detection, means that we identify unusual clustering of disease events and we trigger the rapid investigation and response. Then we monitor the disease trend. We see the distribution and determinants of disease. We track the increase or decrease or decline over the time to understand the population level disease burden. Then we identify the high risk groups where we target the interventions towards the vulnerable populations for maximum public health impact. And then we are able to guide the policy and evaluate programs. We provide evidence base for health policy and measure the effectiveness of ongoing interventions. So these are the key components of surveillance. Number one is the data collection, where we gather the health data from sources like hospitals, laboratories, communities, and registries. Second step is the data analysis, where we apply different statistical and epidemiological methods to identify the patterns and anomalies in that data. Third step is interpretation, where we understand the implications of trends within the epidemiological and contextual framework. The fourth step is dissemination, where we share the findings in different forms like reports, alerts, and bulletins to the decision makers and practitioners. And a fifth component is action. And now we are able to implement the evidence-based public health responses based on the surveillance findings. So there are different types of surveillance, like passive surveillance, which means this is a routine facility-initiated reporting, and this is least resource intensive. Then the second one is active surveillance, where the health authorities proactively seek out the cases, and it has higher sensitivity. Then is the sentinel surveillance, where selected sites are monitored for specific diseases as representative sampling. Then the syndromic surveillance, this is based on the clinical symptoms before the lab confirmation. This is useful in emergencies. Event-based surveillance, which is used for which uses the informal sources like media, community, to detect the unusual events. Now we will explain properly the difference between passive and active surveillance. Passive surveillance relies on the routine facility reporting, and it covers the large geographic areas. Low resources are required for it. Underreporting is a major limitation for passive surveillance, but this is good for common and notifiable diseases. For active surveillance, health authorities actively collect the data. They regularly outreach to the health facilities. It has higher sensitivity and completeness, and this is resource intensive because it requires funding to go to the areas, and it is used for elimination or eradication goals of some specific disease. Then the sentinel surveillance, where selected institutions report the data and representative sampling approach is used. Is this excellent for the, trend monitoring? And this is definitely not a population-wide coverage. For example, we use the influenza sentinel sites, the sites where influenza is more common or reported. Then the syndromic surveillance is based on the clinical symptoms only, and this allows early detection before even the lab confirmation. So this is a rapid data collection in case of emergencies, and this is less specific. It may include the non-cases as well. For example, the ER visits with the symptoms of some specific disease are included in syndrome. Even if someone is presenting with flu um, uh, of any cause, but it is not confirmed on the lab, it is included in the syndromic surveillance. Then we come to the event-based surveillance, which uses the informal sources like media reports, even the rumors, community alerts, and social media. This is designed to detect the unusual health events before formal systems trigger. This serves as an early warning system, complementing the routine surveillance. Requires the verification before action. So there is a risk of false alarms. Which is significant. WHO's Global Outbreak Alert and Response Network, GORN, which is a key example of event-based surveillance. This was widely used during COVID-19 for rapid signal detection globally. Then we have indicator-based surveillance, surveillance which is based on the predefined indicators and standard case definitions. This uses the routine structured reporting from health facilities, and this collects the quantitative data regularly. Daily, weekly, or monthly disease reporting is done, and this is useful for monitoring the disease trends and burdens. And this type of surveillance supports the planning, policy making, and outbreak investigation. For example, TB notification, polio surveillance, COVID-19 confirmed cases reporting, all are indicator-based surveillance. So this is again a pictorial um, form of types of public health surveillance, which includes passive surveillance, active sentinel. We have already gone through it in the detail, so we'll move forward. So these are the data sources in surveillance, which includes hospitals and clinics, which are the primary reporting units, the inpatient admissions, outpatient consultations, emergency visits. Then the second source is laboratories. The laboratories confirm the diagnosis with microbiological and serological testing for accuracy. Then we have vital registration, where the birth and death registration systems are essential for mortality and cause of death data. Then we have surveys and registries, which includes population-based surveys, cancer registries, TB and HIV registries for specific disease tracking. These are the attributes of a good surveillance system. That this system should have simplicity, means it easy to operate and understand. It has the flexibility, means adaptable to new threats as well. Sensitivity means the system can detect true cases accurately. It has high specificity, means it can exclude known cases reliably. Then the timeliness, because rapid detection and reporting is important. Representativeness reflects the true population, and the acceptability means a willing participation by the stakeholders. We do the evaluation of surveillance system as well, where we assess the usefulness. That does the system guide meaningful public health action. We measure the performance against key attributes like we have already discussed, like sensitivity, timeliness, and so on. We identify the gaps, that where do failures in detection or reporting occur, and evaluate the resource utilization, that is the system cost effective. We ensure the representativeness, that does data reflect all the affected populations, and then the regular evaluation ensures the continued relevance and adaptability of the system. So this is surveillance cycle. This is the better form of the cycle, where we start with the collection of the data, and then the integration, analysis, and interpretation of that data, and then we disseminate and take action according to that interpretation, and then we do the evaluation of that system, that should it continue the same way or some changes are required. This is the data flow in surveillance system. We start at the community level, where the community level health facilities like VHU, THQ, then the data reaches the district health office, then the regional the public health institutes, and then the national public health institutes, where Ministry of Health and others are taking care of the data. Um, the data report goes in this way, and then the feedback and supervision flows backward till the level of community health facilities. So the epidemiological indicators used are the frequency measures like incidence rates, which means new cases. Prevalence rates are also used, means all the existing cases at a given time. Attack rates are used at the proportion affected during an outbreak. Secondary attack rates are used, which shows the spread within households. Then the severity and burden indicators are used, like mortality data, which shows deaths due to the disease per population. Case fatality rate means the deaths among confirmed cases. Then we can also use years of life lost, which shows the burden of premature deaths, and then the disability adjusted life years, which shows overall burden of some disease. Then surveillance may be confused with some other terminologies like monitoring and evaluation, so we will differentiate them over here. Surveillance is basically a continuous data collection process, and population health is the main focus. We detect the trends and outbreaks. This is a long-term ongoing process. Standard or disease-oriented system is this. Uh, if we talk about monitoring, this is ongoing program tracking, where we focus both on the inputs and the outputs, and we track the progress of our program, and we do this at regular periodic intervals. And then, if we talk about the evaluation, this is periodic outcome assessment, and we mainly focus on the impact and effectiveness, and this measures the goal achievement, and point in time assessment is a part of evaluation, and this is a results oriented judgment. So this mainly focus on the outcome, and monitoring is more focused on our program, and surveillance is a continuous data collection for the disease trends. Integrated and global surveillance. One of the system is integrated disease surveillance and response, the IDSR, which combines the monitoring of multiple diseases into a single coordinated system. WHO's IDSR strategy is widely implemented, especially in Africa and other developing regions, in our Asian regions as well, and in now in Pakistan as well. Efficient resource use is possible with IDSR, where there is shared infrastructure which reduces the duplication. It strengthens the national health systems and laboratory networks and enables the rapid response to standardized case definitions and thresholds, and it improves the coordination between disease control programs and public health agencies. So these are some examples of the global surveillance systems like WHO Born, we already talked about it. That is Global Outbreak Alert and the Response Network, which allows the rapid international response to public health emergencies. Then the CDC surveillance programs, which allows the advanced epidemiological tracking systems in the United States. Then the international health regulations, which is the legal framework for global health security, and 196 countries are obligated to detect and report the health events. And then GIS, aid, and genomic networks. These are the global platforms for sharing pathogen genomic data. We will talk about it in the next slides as well, which is critical during COVID-19 and influenza seasons, and AMR and other things as well. So these are the examples of surveillance systems in Pakistan. The National Institute of Health, Islamabad, which is a central coordinating and reference laboratory body. Then the disease early warning system, DEWS, which is deployed in conflict and post-disaster settings for early detection. Then the EPI, which tracks the vaccine preventable disease. Polio surveillance is a priority. Then some provincial disease surveillance reporting systems. We'll talk about them, like this one. This is under PITB, the disease surveillance system. They say that the implementation of a disease surveillance system was found necessary so that future epidemics could be prevented and coordinated action could be taken. The system has been operational since July 2013. Data for surveillance is being captured from across the Punjab and from all levels of health care facilities, including the primary health facilities, including 2,828 RHCs and BHUs. Secondary and tertiary level hospitals include 147 hospitals, and the dedicated data entry operators equipped with laptops and other facilities, all of them are available for the working of the system. This picture shows that a range of diseases are covered under this system. They give the monthly alerts, and they show the peak months where a specific disease is high in trend. So this is again the same picture almost showing that different diseases are covered under PITB disease surveillance system. This is their dengue activity tracking system, which is more active than the whole of the system. PITB needs to work more for the smooth working of the system. And now we talk about a digital and modern surveillance, which includes the electronic health records, faster data sharing and integration across the health facilities for near real-time surveillance. The second one is mobile-based reporting. Field workers can submit data via apps. So this is used in polio eradication and malaria programs, dengue programs. AI and big data analytics, predictive modeling of outbreaks using large data sets, anomaly detection algorithms, these are used nowadays. COVID-19 dashboards, these were used for the real-time national and global tracking, which became standard and a model for the future emergency surveillance. So surveillance has a role in outbreak investigation because it detects the unusual increase, and then we are able to confirm the diagnosis and we identify the source and transmission using different epidemiological methods. Then we implement the control measures, and then we communicate the findings to the stakeholders and evaluate the effectiveness of response measures. So this picture shows that how data flows. For the outbreak investigation, we diagnose a case at a healthcare provider facility, and the clinical laboratory confirmation is done, and then the data is disseminated to the local or state health department, and then if any additional investigation is required, that is done, and then after that it is notified to the management officials, and the further steps are carried out according to the outbreak investigation and response steps. There are ethical issues as well in the surveillance, including the individual rights, which include confidentiality. We have to protect the patient identity in all reporting. Then the data security, which prevents the unauthorized access or misuse. Stigmatization risk, vulnerable groups must be protected. And then the equity, surveillance must serve all the populations fairly. Then some collective responsibility lies, like the informed consent, which is may be required where applicable by law. The privacy versus public safety. This is an ongoing ethical tension and which has to be prioritized. Transparency is also important. Communities should know what is collected from them. Accountability, data should be used for the stated purpose only. These are the challenges in surveillance, that there is underreporting because many cases never reach the surveillance system, especially in the rural areas. There is lack of trained workforce, poor data quality, and inconsistent reporting practices. Delayed reporting, late response due to the slow data flow from private facilities, which may be of no use. Resource constraints, financial and technical limitations in the low income settings. Political will, reluctance to report the outbreaks due to trade, travel, reputational concerns, then the data silos, lack of interoperability between different health information systems. This is a very important point. We have to strengthen the surveillance systems through different strategies like capacity building. We have to train the healthcare workers in case detection, reporting, and data quality at all levels. Laboratory network development. We have to strengthen the diagnostic capacity for accurate and timely pathogen identification. Digitalization, implement the electronic reporting systems to reduce delays and improve the data quality. And then the community involvement, we have to engage the communities as active participants for improved detection and compliance. So there are some emerging trends and applications like genomic surveillance, One Health approach, real-time dashboards, artificial intelligence, social media mining, wastewater epidemiology, where we detect the pathogens in wastewater before clinical cases emerge. This picture shows that how One Health is used in surveillance. We do the wildlife, livestock, human interactions. We do the surveillance from the wastewater and we do the sampling and diagnostics, and then we move to the interventions like biosecurity, vaccinations, and AMR control, and we are able to reduce the zoonotic diseases and AMR. So surveillance is helping in this way. Genomic surveillance for antimicrobial resistance. This is the article published in 2023, which highlights that genomic technologies have enabled the monitoring of the mobilization, persistence, and abundance of AMR genes and mutations within and between microbial populations. So their adoption has also allowed the source tracing of AMR pathogens and modeling of the AMR evolution and transmission. So genomic surveillance is also important, especially in this time. Then this article was published in 2024, harnessing artificial intelligence for early detection and management of infectious disease outbreaks. This study explored basically the integrating AI for early detection and management. They say that AI algorithms analyze diverse data sets, including electronic health records and social media, to identify potential outbreaks. So this not only help in the disease predicting the disease spread and severity, but aid the proactive resource allocation as well. We now came to know that applications of surveillance are not only in the communicable diseases, where we also work on the antimicrobial resistance and emerging infections like novel pathogens and zoonosis, but also on the non-communicable and other issues as well, like the cancer registries, environmental health data, and occupational health data, injuries and trauma. So this is the summary that surveillance is the cornerstone of public health. Multiple surveillance types exist, and each is suited to specific disease and context. Attributes of the surveillance defines the system quality. There are global networks, and there are networks working in Pakistan, and we are facing the challenges like under-reporting capacity and infrastructure gaps. And the future is digital, genomic, and One Health, requiring the integrated approaches. So now we come to the MCQs. Question number 1 is: our district health officer notices a sudden increase in acute watery diarrhea. Cases reported weekly through routine hospital reports. No active case finding is done. What type of surveillance is being used? Option A: active surveillance. B: sentinel surveillance. C: passive desyndromic. And E: event-based surveillance.
C.
Yes, C is the right answer. Question number 2. During a dengue outbreak, health teams visit households daily to identify the new fever cases. What type of surveillance is this? Option A, passive; B, active; C, sentinel; D, event-based; and E, laboratory-based.
B.
Yes, B is the right answer. Question number 3. Selected hospitals across the province report influenza cases to monitor seasonal trends. This is example of option A, active surveillance; B, passive; C, sentinel; D, syndromic; and E, integrated.
Sentinel.
Sentinel, because I selected